Hey guys, welcome to another video, Grasp. Today's topic is the ACL and return to sport. So the question that we got was, how soon or how do you know when someone's ready to return to their sport after an ACL repair? So let's just talk a little bit about the anatomy and kind of what goes on with the ACL, and then we'll get into the return to sport. So the ACL is the anterior cruciate ligament. It's one of four main ligaments, the larger ligaments, that's in the knee. And so the main function of the ACL is to prevent tibial translation forward, which I'll show you on the model. So the tibia, that's our shin bone right here at the bottom. This is our femur up top. So I'm gonna turn it to the side. So forward translation. So the tibia sliding forwards. It also prevents hyperextension of the knee. So, you know, the knee, if you bend the knee backwards, and also helps to reduce rotational forces that occur on the knee. The ACL is located, if we bend our knee back, down deep inside the knee joint itself. So down inside here, just above this blue part. That blue is the meniscus that you're seeing there. So that's the ACL. ACL injuries are very, very common, especially with your athletes that are performing cutting movements. For instance, a running back, an outfielder in baseball, soccer players, rugby, all of those folks perform a lot of cutting movements, so change in direction very fast. The ACL is loaded with mechanoreceptors. So these are sensors that pick up information on position, tensile force, and they give that information to the brain. And the brain processes it, sends that information back to the muscles as to how much to contract, how long to contract, and so forth. So how much force to generate in order to perform the movement that we need our bodies to perform. And so the ACL is very, very important in knee functioning. And so whenever you have an ACL injury that requires surgery, there's a few techniques that can be done. There's three types of techniques associated with an autograft. So autograft is where the surgeon takes tissue from the patient's body, from elsewhere, and uses that to reconstruct an ACL. And then there's an allograft. An allograft is used from a cadaver donor. And so the problem with using really any tissue other than the original ACL is, how can we put more mechanoreceptors, these sensors, back into the tissue? Well, you really can't. So that can affect an athlete's performance long term. Whereas before they were very, very agile, and maybe they've, even after their therapy and their retraining as far as their sport, have gotten, it appears to be back to normal, but in a lot of cases there are still some deficits just because of that lack of mechanoreceptor, or that damage to mechanoreceptors. So that is an issue. So going back to the three types when you use patients' donor sites, we have a hamstring graft, a patella tendon graft, and a quadricep graft. And so depending on the surgeon, what technique they like, and of course the situation, that will change the protocol as far as for therapy and how that patient has progressed through the therapy program. There are certain restrictions and certain things you can and can't do. And so it can be, you really have to know which technique the surgeon used and then what their protocol is to ensure that you don't cause any damage or cause the surgery to fail. And so with that also, you're discussing failure of surgery. There's around 250,000 ACL surgeries are performed a year, and of that, almost 80%, if they return to sport less than 5 months post-surgery, will have a re-tear. And so re-tear, of course, they're down a whole nother series of surgeries and therapy and then sports performance programming and all of that. So you really have to make sure from start to finish that you really monitor everything so that there's no issues, no hiccups along the way, and everything progresses nice and smoothly. And so with ACL, so then how do we know when the athlete's ready to return to sport? That was the specific question that was written in. And so with that, the gold standard for years has been the HOP test, and there are 4 different types of HOP tests that can be done. And typically, you look at most research, 9 months or greater before return to sport is ideal. So for every month that the athlete post-surgery waits before they return to sport, decreases their chances of re-injury by 51%. So the longer out they can be, of course, depending on where they are in their season, whether they were in the off season, maybe in practice or something like that, versus in season. All those things kind of have to play in because you have to get the athlete ready to go back to playing. And so usually 9 months or greater would be ideal. I mean, if you could have 12, 14 months of rehab and sports performance training, that'd be great, but sometimes that's not feasible. But anyway, so we go back with a hop test. And so with a hop test, there's 4 different types of hop tests that can be done where the athlete, hops on the affected or the injured leg. You also have them hop on the unaffected leg so you can compare. You want to get a good baseline and compare one leg to the other as far as making sure that that you're on track with where they should be in a normal knee situation. The single leg hop test and the triple leg hop test through research has been found to be the most reliable. There's one that is a crossover hop test and a timed hop test, and there are some variables that go into that the consistency on that is not really that great as far as predicting consistent results, so to speak. Not necessarily predicting long-term outcome, how they're going to do long-term, but just the results during the tests themselves. And so there has been some conflict with the hop test because it doesn't necessarily show long-term outcome per se as far as how the athlete's going to perform in their sport, but what it does show is consistent measurement of where they are as far as being able to perform it versus not being able to perform it. So you still perform it just to get an idea of where the athlete is, but you need to take into consideration a lot of other things. What is the range of motion of the knee joint? How much pain does a person have? What is their movement in other planes of motion? And then also with weight shifting, those cutting movements, diagonal movements, those types of things. How does the athlete perform that? Is there pain, is there no pain? And how fast is their reaction time? Because remember, those mechanoreceptors play a big part into the reaction time of an athlete with change of direction and plyometric or explosive movements such as jumping. And then of course, landing, the eccentric force of when you have to land and absorb those forces. So again, with ACL, it doesn't have to be a big scary thing. A lot of people, athletes, that think, man, ACL is a game ender or career ender, and it doesn't have to be. If you couple it with the right surgeon, therapy staff, and then with a strength coach or performance coach, then you can guide the athlete through the whole program and hopefully be able to return back to their sport with limited to no restrictions whatsoever, and then they can continue on. So with that, again, overall, it depends on the surgeon, the protocol, the therapy protocol as far as rehabilitation, and then overall how the athlete is doing as to when they return to sport. But in most cases, if you look at most research, 9 months or greater typically has the best long-term outcome as far as return to sport. If they're in that 4 or 5 month range and try to go back, their risk of re-injury and re-tear is very, very high. So I hope that helps. And you guys keep your questions coming. Thanks so much for writing in, and we'll see you next time.